Now coming to the next question, there's a similar kind of a question with a slight tilt here. This person is 63-year-old man, diabetic patient, 63 year, you have to see the age, you have to see the gender, male, diabetic patient, and diplopia is worse on upward gaze. So you always have to see that in which gaze diplopia is getting worsened, because in that particular gaze, the muscles that will be working will be the important ones. Ductions are full here. However, in the up gaze, the left eye only elevates the halfway. That means I have got a problem in the left eye elevators. Yes or no? Because this eye is not elevating full. There is only halfway elevation. Pupils in remainder of the ocular examination is normal. So, if you look at the elevators of the left eye, we have got the LPS muscle, we have got the superior rectus muscle. These two muscles are the elevators, but because pupils are normal, rest of the ocular examination is normal. That means the medial rectus is not involved, the pupillary means secretomotor fibers are not involved. Yes, that means we have got selective involvement of these two muscles, and these muscles are supplied by third nerve. Now, can you tell me any condition where third nerve is involved, okay, but the rest of the examination is normal? Because you already know that this third nerve supply all the extraocular muscles except for SO4 and LR6. We already know. So, if I have a third nerve palsy, I will have the involvement of the medial rectus also, superior rectus, then inferior rectus, and all these muscles. But they are saying that just there is a problem in elevation, rest of the involvement is not there. That gives you a hint that we have the involvement of only a particular division, that is your superior division. That means only the superior division of the third nerve is involved, and it is the selective involvement of the superior division of the third nerve which supplies the LPS muscle and the superior rectus that can cause a problem in elevation. So, this is very, very clear. Now, let us see the question. So, this question has two parts. The part number one is that the patient gets a CT scan. Where would the lesion be located to cause this condition? The options are brainstem, cavernous sinus, the junction of the posterior communicating and internal carotid arteries, or the orbital apex. Please give your answer in the comment section. What is your answer? Please give your answer in the comment section. So, the answer is pretty simple. It is orbital apex. Why? Because it is the only place where you are going to get the alone involvement of the superior division of the third nerve. Posterior to the orbital apex, we have the combining union of the superior and inferior division. So, this is again your anatomy, medicine, ophthalmology integrated here. Okay, you cannot say that it is one particular subject here, because this is your neuroanatomy knowledge also. You know that posterior to the orbital apex, you have the union of the superior division and the inferior division, and therefore, it is only up to the orbital apex if the trauma is there. If you have involvement or any lesion is there, then you can have just the involvement of your superior division. Okay. Now, if you look at your option number B, part B, what finding would most likely accompany this examination? So, if you look at the picture also, can you look at the picture? When the patient is looking in the upward gaze, okay, so the left eye is not able to go that much. If you look at the levels, this eye is much above than comparison to the left eye, so obviously left eye is not able to go up. So, on the basis of this, you have to see the options. The option number one is right upper lid retraction. Option number B is left nystagmus on up gaze, miotic left pupil, or chin down posturing. Now, let us start with the D option, chin down. Now, I have got left LPS involvement as well as left superior rectus. Due to the involvement of the LPS, now what is happening? There will be ptosis. So, there will be ptosis in the left eye. Now, what will happen? If there is a ptosis or the drooping of upper eyelid, this will cover the pupil, person will not be able to see. So, whether this person will do chin down or chin up, the person will do chin up so that he could clear the pupil and can see. So, obviously, this is wrong. This will not cause chin down. This will cause chin up, number one. Now, number two, whether this will cause meiosis, No, because only the superior division is involved, therefore this will not cause miosis, and they have already said themselves also that pupil is normal, rest of the ocular examination is normal, so that is gone. Then we have got left nystagmus on the up gaze. Now third nerve palsy does not cause the nystagmus, it is actually the right MLF lesion. If I have this you have already seen in the question number 1, if I have got a right MLF lesion, then I will have left abduction nystagmus. So this is also not there. So by default also your answer is this, A, right upper lid retraction. Now I will tell you how. See what happens if I have got, suppose this is your right eye and this is your left eye. Okay. So left eye is having ptosis. Okay. Now in order to elevate this eye, now the person will send more innervation. The person will send more innervation to the LPS muscle because you want to see, elevate the eye. So what is happening according to the Haring's law? What is the Haring's law says? According to the Haring's law, equal and simultaneous energy will go to both the muscles, to the yoke muscles. So what will happen? The same amount of energy will go to the right LPS also. Same amount of energy will go to the right LPS. Now the left LPS is paralyzed but not the right LPS. So this will cause the upper lid retraction. And that is why this person will definitely come up with the right upper lid retraction. This is again a very important and a beautiful concept that you learn from the Haring's law. This person will give more stimulus, more innervation to the left LPS to elevate the eyelid, and that same innervation will go to the right also, and that is why what will happen? There will be more innervation and that will lead to the upper eyelid retraction. So two important questions linked to the one. Okay, what is the site of the lesion and what will be the findings? All right.